Hi, everyone. Thank you so much for joining us. I'm Alice Casey. I work here at Middlesex DA Marion Ryan's office. Marion's going to be joining us, but she's running just a few minutes late, so I'm going to kick us off. We're really grateful that we have two excellent speakers today. Our first speaker is John Kelly. Some of you who have been with us for some time probably are familiar with John because he um, joins us usually a couple times a year just to tell us what his organization has been up to and to give us some data. John is the Director of Communications for and IT for Pride Star Trinity EMS. He and his coworkers provide 911 coverage for 7 communities. He leads the Pride Star Trinity EMS data assistance efforts. He also helps EMS and public health agencies across the county implement EMS data assisted programs. And John's going to tell us during this session about some of the data from this past year, 2025. So John, thank you so much. The floor is yours.
Thank you so much. All right, everybody can see that. That's up and we're good. All right. So in 2025 in Lowell, we experienced 443 non-fatal opiate-related 911 calls. And for us, that was pretty consistent to what we saw in 2024. We're going to take a longer look at kind of the last 15 years in a little bit, but we kind of want to start with that, kind of put that in perspective. That's the lowest numbers we've seen in non-fatal overdoses in Lowell since 2013. And I know with the pandemic, everything gets kind of wonky as far as timelines go. So we kind of wanted to put that into perspective, couple little things there, kind of let us know what 2013 was in our world. Last year in Lowell, we had 296 instances that someone took an opioid, went into respiratory arrest, 911 was activated, Narcan was given, and a life was saved. So for the next, 15 to 18 minutes, depending on how quick I talk and how many breaths I take, we're going to kind of go over kind of the data a little bit to kind of let you know where it's coming from and that it's available to almost any community if you kind of do a little bit of the legwork. We're going to talk the data for 2015 for Lowell. Then we're going to go take a step back and look at 15 years for Lowell. And then we're going to look at 15 years system-wide so you can start to make some kind of thoughts about what's going on in your own communities as far as when and where overdoses happen. So just a little bit, just a kind of quick disclaimer. If anybody on the call is from Marlboro or Hudson, well, we are now your ambulance provider. If I haven't met you before, that's my email. Please reach out. We're happy to either kind of bring what we do for the other communities into yours, or if you've got specific needs or requests, we're happy to kind of work with you and figure out what we can do. So all of the data we're talking about today comes from our non-fatal patient interaction. So every interaction we have with a patient, we create a patient care report. The data set is from 2011 until last week. So it's about 17,000 calls, and there's over 1 million points of data in the system. The part that everybody has, so we have this thing called NEMSIS, which oversees us. So whether you're Billerica's police ambulance, your Woburn fire-based ambulance, or your private vendor, we all have the same federal requirements to get information. So theoretically, every piece of information we provide is available for those communities as well. So we get our information kind of 2 paths. So we use an automated program called First Watch. So in Lowell, we have a co-op team, which is run through the health department, and they do follow-ups. So whenever there's an overdose in Lowell, that team member, those team members get automatic notification. They get to see the patient care report right away, which then allows them to kind of provide that outreach quicker instead of having to wait for kind of notification and a different process. The information we're going to talk about today is from our manual system. So since 2016, we've read them all. We went back to 2011. So someone, his name's Joe, has read those 17,000 patient care reports, every one of them. Most of the information we glean is extracted, the date of birth and all that comes right off the patient care report. But a lot of it, Joe reads and interprets and gets it from the narratives of the call that the paramedics and the EMTs write. So one of the things we produce is a monthly opiate report. So if you've seen one of our reports from one of our communities, this is it. If you represent a different community and you're kind of looking for a starting point, just email us. We're happy to share it. It's a public document. There's nothing classified in it. We'll just kind of go over that briefly. Those are kind of the data points we show, and in the red box is kind of where I wanted to bring attention to. So in January, there were only 4 instances where someone needed Narcan to be saved. In July, there were 51. So in 180-day, it's almost like a different world, right? So you go from 4 to 51 in a relatively short period of time. Underneath that, the Narcan use, we always want to call out our partners at Lowell Fire and Lowell Police for the wonderful work that they do every day. And that other at 24, we'll come back to that in a few minutes because that's the best part of the whole presentation is going to be that. And then at the bottom of the report is kind of, you can see 11-year span of kind of where we were for averages and whatnot. And those two blocks, so that's the month. So this is July, so there's 31 days of July. So on July 1st, there were two. The red is weekend, so Saturday the 5th, right? We had 4 overdoses, but then on Sunday the 6th, we had none. So you can see there's several days we didn't have any overdoses. And then some randomly on the 30th, which was a Thursday, we had the most at 7, right? So you can kind of get an idea for the flow that it's not consistent. It's very kind of random in some ways and then predictable in other ways. So we're going to talk just now for the next few slides here of just 2025 in just Lowell. So the 443 opiate-related 911 calls we had last year, again, that's month by month total. So you can see we have some in the teens and then we have some in the high 60s. So seasonality seems to have a major impact on overdoses and when they're happening for us. Even within Lowell, so it's not evenly distributed, right? So, we have 2 neighborhoods had 64% of all overdoses where other neighborhoods didn't have any. And we bring this up, so this is really, EMS generally is underutilized for kind of the information we know about what's going on from a public health standpoint. But this really highlights the importance of EMS in the GIS department in the town. The shapefile we got for this was from Lowell Police or the Lowell GIS department. I think it was back in 2009 we got this. And ever since then, if someone, I don't know why they would want to, maybe they can't sleep, but if someone wanted to know, the difference in ankle fractures in Lower Belvedere versus Sacred Heart, right? All that information is already in the system. And again, that's kind of being able to utilize your EMS agency and your GIS to get even more information about what's going on. And the impact from outside of the city. So of our 443 calls last year, 119 were not residents of Lowell. So from an outreach standpoint, right, how do you provide outreach for patients who don't live in your community? And last year in Lowell, we had over 40 different communities have a resident come in and have at least one overdose. So, right, clearly there's more from the surrounding communities, but there's also patients that, drove an hour or ended up an hour away and had an interaction with the 911 system for Lowell. So of those patients, so this is a subset. So we had 296 patients that needed Narcan. So that 443 were, if they hadn't used an opioid, we wouldn't have interacted with them. But 296 times we found somebody to be in respiratory arrest. And again, those are those numbers we talked about a few minutes ago, 4 in January and 51. If you think about that even a little bit more deeply, so in January, we were doing 1 a week. In July, it's more than once a day. So again, just a completely different world, even though it's only 180 days apart. And those 296 incidents were 200 different people. So if we think about it, if every overdose was fatal, right, Lowell would have had 200 additional deaths last year from just opioids, just in 1 year. So this is the biggest success. So if you're not a data person and that guy's just talking, so come back for a sec. So this is really I think this is the highlight of kind of everything that's going on in Lowell, going back to when we had the DA's meetings live and every month up at Lowell General, and you have all the different people from all the different worlds get together. And we started talking way back then about how do we get more Narcan into people's hands. And this is the success. So in 2016, only 10% of the time was somebody on scene giving that dose before Lowell Police or Lowell Fire or the hospital, Lowell General Paramedics or us showed up. And you can kind of see it jumped up into 19, right? So you're right around the pandemic, we're at that 30%. And the last 2 years, we're over 40. And I think if you correlate that with the death rate going down as well, right? That's a lot to do with it. We're able to get Narcan and get patients breathing again, even before Lowell Police show up or we show up or fire, which again, just a huge success. So now we're going to talk still just Lowell, but we're going to look at 15 years. Okay. So just to kind of show the journey that we've had. So in those 15 years, we've had 7,748 opiate related 911 calls. So these are non-fatal 911 calls. You can kind of see that journey down to 2011. We had 190. 2012, we got a special project and we started putting Narcan on the BLS ambulances. 2014 is really when we think fentanyl showed up in our communities. It kind of keeps going up until 17 and 18. Really big reduction down in 19. The pandemic in 2020, and then it kept going up. And then the last 2 years, again, we had that decrease down to the 460 and 443. So again, we hope this year that it continues to fall down. So again, this is a subset. So in those 15 years, we have 4,368 documented instances that a patient was found to be in respiratory arrest and Narcan given. You can see we had 43 back in 2011, up to 468 in 2017. So you can kind of see that journey that we've been on kind of up here in the valley. So those 15 years were 2,700 different unique people went into respiratory arrest once. So there's 4,368 instances, and there's 2,700 different people. So clearly a few people we've interacted with multiple times. So you can kind of get a gauge. I think the most we had was somebody was over 20 instances. And honestly, if they're still with us in the area and haven't moved, we're help them the next time too. So now we're going to kind of step even broader. So we're kind of presenting this as maybe the information here can help you in your own communities as well. So we're talking 2011, 2025. So this is a bigger set. So this isn't just Lowell. So you can see the communities over to the left that are in Middlesex County. So your communities are in that data, and over to the right are kind of the other systems. So this is about 12,000 or so calls, right? So we want to kind of show these as generalities. So for us anyways, so the setting of the overdose. So in our community of Lowell, over 100,000, 60% of our overdoses happen in the public space, right? So from a public health standpoint, an overdose happening in a private home is different than an overdose happening in a public space. Oh, I hit a wrong button. And then if you go down to kind of that middle ground, right? So our communities of anywhere from 20,000 up to just under 100, and Haverhill, I think, is 80,000 or so. We go to 39% of our overdoses are happening in the public domain. And then we go to our bedroom communities, our smaller communities, under 25,000, only 13% of the overdoses are happening in the public domain. So if your community is kind of in that range, right, it will impact how you try to do outreach, right? If all your overdoses are happening in private homes, the outreach for that, I think, would be different than if a lot of your overdoses are happening in a public space. Kind of just some random, well, not random, but some other data points. So most of our patients are male, right? 71% to 29. Our population age, it tends to be older than most people expect. And it's mostly because we have a fair number of 50, 60, and 70-year-olds that overdose. And we don't have, thankfully, very many teenagers or even in their 20s. So if you think about, the N of 12,000 instances, for every one 60-year-old to get back to kind of a 30, you'd need a teenager, which thankfully we don't have. So that's why it's kind of a little bit older population than most people would think. You can kind of see the breakout by race there. And again, we have more white females than white males. And really what we end up with is more Hispanic males than Latina women. So that's kind of that difference, right? And again, that's from that large data set of over 12,000. So this is when all the overdoses happen, by day of the week, by hour of the day, right? So there's absolutely a rhythm to the overdoses that we see through 911. So a dark green is the fewest, and then you go to kind of yellow, which is the middle ground, and then the dark red is the most. So if you look at that, the most of the overdoses, right, are happening 3 to 9 at night. And if you kind of look even more Thursday, Friday, Saturday, 3 to 8 is really that hotspot. So if you're going to do outreach, is the time to do outreach before people are overdosing? So is that, 11, 12, and 1, or do you want to be out in the field when the overdoses are happening? And that tends to be a later event than kind of earlier in the day. And again, 12,000 or so calls. So monthly, right? So we talked about this a little bit earlier, where we had so many more overdoses in June and July than January. And so this is that 15-year span. So if you think about it, right, if every month had an equal number of overdoses, it would total about 8.3%, right? So 12 divided by, the 100%. So anything under 8.3 is underrepresented. So January, February, March, November, December are underrepresented with the number of overdoses if everything was equal. And then you could see June, July, August, September are overrepresented, right? So if you kind of put the last two sides together, when are most of your overdoses happening? Well, the Thursday, Friday, Saturday, 3 to 10, July, June, July, August, and September. So maybe with that, you can kind of fine tune when you're doing outreach or the type of outreach you're doing. And then kind of coming towards the end of things, so newer options for EMS. It is within the mass OEMS protocols for leave behind Narcan. So we do it a lot. Every one of our ambulances has Narcan in the trucks. We can leave it on any call, right? So sometimes a lot of times we're interacting with patients and families at their most vulnerable. So there's a window there that maybe isn't normally open. So we always try to take advantage of that. It's pretty simple. You give them 2 minutes of training, and we leave the Narcan behind with them. For Lowell, we have the business cards for the city of Lowell's co-op team. So we'll put that in the box. That way later on, if they're kind of looking for more of it, they have a direct link to them. Again, we want to lower the bars to success and try to help people when they're ready. One of the things we do see is we have a lot of patients that get a lot of Narcan. Like we'll get a 911 call and we get there within 2 or 3 minutes, and the patient's gotten 4 or 5 doses of Narcan. So they're getting really, really acute withdrawal symptoms pretty quick. And I get it. I understand, like you give Narcan, it's not instant. And family, friends, loved ones, you kind of panic a little bit. We'll give another dose. We'll give them another dose. So what's happening, we're getting people that are kind of getting into really acute withdrawals. And one of the wonderful things Massachusetts OEMS did in last year's protocol was allow for field buprenorphine. So that's one of the things that we're working with the city now to bring, hopefully by midsummer, onto the trucks. We're going to be a little bit different. We could be the first agency in the country from a BLS. So not to get too deep, but EMS is kind of broken into tiers. So there's an advanced level and a basic level. Almost everybody in the country has buprenorphine. It's that advanced level. Most of the ambulances in Lowell, because of kind of the type of calls we do, are that basic level. So there's a couple extra hurdles for us to do that, but we do plan on bringing the buprenorphine. Again, so many of our patients that get 16, 20 milligrams of Narcan from bystanders, when we get them to the ER, they kind of run away, right? And they're not getting that follow-up help that they need, that everybody's kind of working towards. So the idea is if we can get buprenorphine, that can take away a lot of that sickness, and then maybe they'll stay longer at the hospital. There's been wonderful success around the country as far as getting kind of that 30-day follow-up mark when field buprenorphine is in place. And that's what we're kind of hoping to draw on. And those two ideas really, obviously not an abatement fund expert, but, I've done some reading and whatnot. So the opioid settlement funds, those are kind of revenue sources for those two programs right there, if you're looking to kind of bring it to your community and your EMS agency. And I'm going to take a deep breath. So thank you for the opportunity to be here and present. That's our contact information. If anybody wants to kind of have any follow-up, we're always happy to help. We're happy to learn if you're doing anything else. And I'm going to stop sharing now. If I can move my mouse over. Okay.
John, thank you so much. That's amazing data. And I'm going to talk a little bit about how important that has been to us. But anybody have any questions, comments for John? And I can't see everyone from where I'm doing this, so feel free to just speak up if you have a question or put it in the chat.
I have a couple questions, John. So thank you very, very much. One of your slides showed that on the 30th of a particular day, there were 7 calls. Which was that? What month was that?
That was July 30th.
Okay. And was that this past year?
Yeah, that was 2025. Yeah.
Okay.
I think the most we've had was, it goes back to, I think it was 2017. I think we had 12 in one day. And that's, so that instance, so that data point is why we use First Watch. So that's what we use for the City of Lowell surge protocol. So we have kind of a system set up that there's more than X number of overdoses in a span. Basically what happens is we monitor it right from our patient care reporting when it hits that threshold. Basically how it works is I'll call Lisa Golden, that's the health director for the city. And then Lisa will kind of talk with the police chief, fire chief, and then we have a surge protocol that they'll put out. It's basically like a social media and an email chain that goes out to the communities. And I had a slide a couple years ago, kind of like Pepsi, right? If you go into New Mexico and buy a Pepsi, it's the same as one you buy here. But if you're buying an opioid from a street from somebody, the opioid you get right now, it can be completely different than the opioid you get from the next dealer that's a block over, right? So that's why you have these giant spikes in overdoses, right? If it was a consistent stream, right, people could get used to it. But we have these wild swings in it, which is why we have the opioid protocol in place in Lowell.
Great, thank you.
People are talking about what a great asset you are in Lowell, John, and it's true not just to Lowell, but to all of us.
Thank you.
Anybody else? Questions, comments? All right. Thank you, John, as always.
Sure.
And I want to just talk a little bit about that data, and Happy New Year to everybody. Sorry, I was a little behind, but we are now 14 years into this task force, which seems amazing to me. And it seems, as John has shown, we've made just incredible strides, both in terms of our numbers, in terms of the use of Narcan. John will remember early on, we were battling with people whether we could put Narcan out and who we could give it to. And I literally was breaking the law for a while because the only way we could get it was we ultimately got an emergency room doctor to write a blank script for our office so that we could supply it. And, we've come so far from there. And it really is based on the teamwork, the people who've been here, and the data. And, Pride Star Trinity has been with us from the very beginning, from the first meeting around the conference table up in Lowell when we started this task force. They've been committed to this. And with John's work and the way they've been able to collect the data, many of you will remember those first 3-4 years were very hard because we were working incredibly hard. There were all kinds of resources, and yet the numbers were just jumping ahead of us, and we could not seem to figure it out. And really, it was having the data and figuring out where are the days. I can remember the first time we figured out, that we needed to get water out on the street during the summer because overdoses increased dramatically on very hot days. And I was literally on the phone and with Pride Star asking the city to put water just all over the place on the street, cases of water. Those are things that really helped us to refine our approach. It helped us to do better. And it really has helped us to have, for the last 8 years or so, just a continuing decline in numbers. Many of you remember last month I said when we met just before the end of the year, we were just short of 100 overdose deaths. And again, always keeping in mind that one is too many, and everybody who loses their life on a conservative estimate has impacted 10 people. But the idea that we would get in the neighborhood of 100 was something we couldn't have imagined when we began this task force. And when we really ourselves didn't know a lot about opioids. I remember when we started this task force, the first piece we asked the hospital to do when they agreed to host us was, can you tell us about what an opioid is? What does that look like? What do you use for that? How does all of that work? And we've come so very, very far in that. And it has resulted in the saving of so many lives. To have over 40% of the people already have had a dose of Narcan when people get there to give help. That's an amazing change in where people were. And that really has been working in education. We were one of the first places that heard about the Harvard students who wanted to put Narcan on the subway trains. And now the T is involved in making that available at stations all over the lines. That's a big change. So I'm incredibly grateful. Very grateful to Pride Star Trinity for all of the years they've been partners with us, to John for developing that information in a way that, you know, he comes faithfully to talk us through, to see what's happening. And to all of you for being partnership in this work with us. And, you know, we know that January is, which we're halfway through at this point, obviously meeting, but it is Substance Use Disorder Treatment Month. And it's again an opportunity to raise awareness about treatments, about paths to recovery. I was yesterday at one of our drug courts, and it was a graduation, which, if any of you have ever been there, is just really one of the most emotional moments you ever see in a courtroom. People who have gone through the drug court, it is at its shortest, it is a pretty grueling 2-year program. People often take more than 2 years because there's been a misstep. But to see where people are, one of the women graduating yesterday, who, when she began, had 34 open cases across Massachusetts. She had been literally revived over 50 times with Narcan. And to see her yesterday, now employed, she's gotten her children back. She's really self-supporting, and she is actually involved in volunteering in treatment programs. So it is amazing. And it is also the message, which I don't know that we were so sure of 14 years ago, that real recovery is possible. Not just going from overdose to overdose, but actually rebuilding a life and being able to move forward from an opioid addiction. And we now have so many examples of that. And that is due to the work of people like everybody on our task force. I want to turn now to our next speaker, Bridget Nicholson. And Bridget is the program director for Anchored in Recovery. She has over 20 years of experience in the addiction and recovery field. She began in 2017 at Spectrum Health Systems, working in inpatient detox, starting in admissions. Then she transitioned to case management. And then she made her way to Everyday Miracles Peer Recovery Center in Worcester. And she was there from 2019 to 23. And she's really, through all of that work, fostered statewide connections within the recovery community, harm reduction. She's done harm reduction, education, and advocacy for just the people I'm talking about, those seeking wellness and recovery. Her mission is to educate about the benefits of compassionate care and the autonomy, which she really believes are the foundations for recovery. Bridget is one of the 4 women featured in the award-winning documentary Recovery City, which aired nationally on PBS last year, and is currently she's currently on an impact campaign tour throughout the United States with that video. So, Bridget, thank you for being here to talk about Anchored in Recovery's work. Thank you.
Thank you very much for having me and everyone that's on today. The work, you know, we're all doing is at the top of the importance level, right? With the firm belief that recovery is possible for anyone. I love this. So yes, I am the program director for Anchored in Recovery, located here in Framingham. We are at 19 Concord Street, Suite 1. If you ever take a ride over, we have a big parking lot in the back entrance, free of cost off Howard Street. Just a little navigation there. So to start off with, you know, saying a peer recovery support center, if you ask me, I pride myself in thinking every peer recovery support center is the heart of that area, that community. Anchored in Recovery Peer Support Center is a peer-led space. It offers support, activities, and resources for people in substance use recovery, and also those that haven't found recovery yet. It supports families, right? We partner with families, allies. We offer hope, belonging, and community through shared lived experience. And this is in a non-clinical lens. Our staff are proficient in case management duties such as treatment access. We have recovery support, navigation, and peer-to-peer support within the building that are non-staff. We provide education, social events, social groups or wellness groups, linkage to services, right? So we pride ourselves with, I'm still learning a lot with Metro West. I'd like to think that I have my hands in many things, or I have my staff in many things, but just reestablishing, already made connections in the past, establishing connections with new agencies or organizations that are coming out, and creating those partnerships to be able to do, handoffs, warm handoffs with these individuals that may not have a strong voice for themselves yet, so we can partner up and connect. We promote an all recovery lens, a multiple pathway, infinite, if you will, in a welcoming environment. So when I had mentioned one piece of that being, support groups, social, just wellness conversations among peers, we do have a calendar of activities, ranging from fun, right? Social activities, going to Six Flags for members, some that have never been to something like that, going bowling or miniature golfing, maybe a trip to the zoo. And then we also have different workshops and groups such as AA. We are in the AA book. We've got meetings at Anchored. Wednesday night is NA, Friday nights is AA, and Sunday from 6 in the morning till about 10 in the morning, there's a couple of groups that rent out our back space. So there's at least 3 days of, off hour type of things, nighttime and mornings on Sunday. During the week, we offer AA at noontime in our front meeting area. Sometimes we could see 3 individuals and they leave that space with a smile. Something that was just shared with me last week was we really needed that, right? We offer refuge recovery, all recovery meetings, community meetings. We host those once every 2 weeks where we invite local providers or new services that we may have heard to come and share those services with our community members. And oftentimes we may work out that they come on a regular basis, such as the Phoenix Recovery Gym travels out here after going to the women's prison. They come over here and do a yoga on Tuesday afternoon. So very, very, very various different types of things. We have art and recovery. Men's support actually just started 2 months ago. I've been with Anchored for 6 months now. So we have a couple of new things kind of rolling out. But the men's support group is every Tuesday at 11. And it's just that space where the guys can either choose to speak about a specific topic that they might agree is something that they could benefit having a discussion together about, or it could be just a space for them to have comfortability and share where they're at today. How has their day started? And if it's in a bad space, 9 out of 10 times talking about it with your peers might bring you to a little bit of a better space to go on about your day and sustain your recovery just in that day alone. We have a special guest, actually, a gentleman that goes by Mathematics. He's from Bedrock Recovery, a Boston area, and he's going to be here on Tuesday, the 27th, to kind of share in that conversation, specifically men in recovery, the challenges that come along with that, and possibly fathering challenges as well. So we have a Just for Today in the morning, and building wellness and resiliency is something that that's the one group that I think is probably rated the top here, and together, and that nobody's wrong, nobody's in the wrong place, nobody has the wrong vision, because it's all, meeting somebody where they're at and understanding that our addictions and our wellness and our recovery path may look different from the person next to ours. Another thing we offer is volunteer opportunities, being able to put place a platform for somebody to be able to step onto, seeing opportunity, seeing strength within somebody and providing that. So we have a lead stipend member, which is a stipend position that gets paid $300 per month, and they have to run a certain amount of groups here. They have to have been implemented in the center for at least 6 months before taking that position. And ultimately, That is what paves the way for staff to take like a step back and a back seat, if you will, and allow that peer lead to kind of lead that, make reminders, enforce different policies. We are a drug-free space, right? But we're also a harm reduction space. We want to embrace those that are still sick and suffering, give them opportunity, treat them with compassion, because supported people recover while maintaining, you know, the structure of our policies and procedures within the center for recovery, success, and safety. We have recovery coach and mentorship, front desk volunteer opportunities where we could potentially give a reference for somebody's first job. Clerical, you're answering phones, you're taking messages, you're welcoming and greeting people, you're, you know, making copies and filling the resource board if it gets low. And you might even get some training that's paid by the center to be able to do group facilitating through BSAS trainings that are offered to the members that are, you know, ready for that next step. And with that brief description, I did want to open, if I could, any questions? If not, that's fine too. You can come on over. We don't take referrals or anything like that. It's a walk-in basis, and you really don't need to meet any specific demographic as well.
So I had a question, but you answered most of it. Do you have like a flyer or something that we can put out? I also run a webpage that I'd like to put your contact information on as well. So I don't know if you could
Absolutely.
send that, or should I put, you can send it to everybody, or if I put my
I-
email address?
I can share my email in the chat, and
Okay,
you can reach right out to me and let me know what you need. And one last piece, I know Mary and Ryan did mention Recovery City documentary. Anchored in Recovery does have an Eventbrite put up. You can find that on recoverycity.com as well. We have a free screening this month, January 27th at Anchored in Recovery. The doors open at 3:30 for some light refreshments, and the film will start at 4. And there'll be a questions and answers panel after at 5:30.
Thanks, Bridget. Anybody
Thank
else have
you.
any comments or questions? No? Good. Thank you. That was good information. Anybody have any comments, things they want to promote, questions? People need anything, Narcan, any of that? Alice, can you just take a look at the chat?
Yep, no, we're good.
Okay.
Thank you.
All right. Thank you, everyone. Thank you so much. We'll see you next month. Take care.
Thank you.